Hello, hi friends, hi everybody joining us today. I hope you can hear and see me loud and clear. If there is any issues, please raise the concern. I am Dr. Pawan. I am an orthopedic surgeon, and I am here to take your class today on the topic fractures of the upper limb. First of all, I would like to welcome you all to Nextillo, which has given us a platform to take this class. I would like to thank Dr. Sunil Sharma for this opportunity. At the same time, I would like to bring to your notice that Nextillo is giving away a helping hand coupon so that all of you can join us and we can help you on this journey of yours to clear your exams and clear your concepts. So without further ado, let's jump into the topic of today, which is fractures of the upper limb. Now, the aim of this lecture is to bring to you all the salient points which are important from exams perspective and the questions which are going to be asked because they have been repeated again and again from this topic. So first, let's quickly jump into the Salter-Harris classification, which is commonly used for fractures in children. Now, as you can see here, there are 5 classifications in Salter-Harris classification, and each fracture has been divided accordingly. Now, if you can see that there is a simple mnemonic for you to remember this classification system. Now, the first is the type 1 fracture, which is straight across, which means that there is a separation of the epiphysis from the physis at the growth plate. This is known as Salter-Harris type 1. In type 2, we can remember it as A or above. Now, above means that the fracture has extended above the growth plate and it is going into the metaphyseal region. Type 3 is basically low or below, and as you can see here that the fracture is extending from the metaphysis through the growth plate into the physeal region. So L is low or below and L is type 3 fracture of Salter-Harris. Now in type 4 fracture, the injury goes through and through, which means as it goes from the epiphysis into the metaphyseal region through the growth plate. This is the type 4, which is known as through. Type 5 is the crushed type of injury, or ER, or we can remember it as erasure of the growth plate. Then, or R, we can remember it as the crush injury, and type 5 is the crush injury of the growth plate. Now, some important points to know about the Salter-Harris classification system is that in the type 2 Salter-Harris, it is also known as the Thurston-Holland sign, and the type 2 is the most common type of pattern seen in the fractures in children. Now, type 5 injuries, type 3 injuries, and type 4 injuries, if you can go back and see here, now type 3, 4, and 5, all these injuries are going through the growth plate. So all of these can cause alteration of the growth plates in these fractures. Now, type 5 injuries are the most commonly implicated injuries, and these are the ones which cause the most deformities and limb discrepancies. Now, imagine if the growth plate is crushed through and through, then obviously there will be altered growth of that involved part, and hence that growth, the bone will not elongate as much as the normal side, and hence there will be a limb discrepancy or shortening. In some cases, if half of the physis is gone or crushed, then what happens is the normal physis keeps on growing, the abnormal physis stops, and that leads to deformities because one part of the bone is growing, the other part has stopped, and that leads to deformities. Now, type 1, 2, and 5 are usually managed conservatively because 1 and 2 can be managed by simple conservative management by slab application. Type 5 are the crush injuries and we cannot do anything about it. Now type 3 and 4, in which there are separations of the fractures, we can manage by reduction and fixation with K wires. So let's come on to the first fracture of the day, which is the clavicular fracture. What we are going to do is we are going to start from above and we are going to go down in the upper limb. Now, fracture of the clavicle are the commonest fractures in the newborns and even in children. The most common site of these fractures is they fracture at the junction of the middle third and the lateral third of the clavicle, and that is the most common site. The most common mechanism of injury in clavicular fractures is foosh. Foosh means fall on the outstretched hand. So fall on outstretched hand is the common mechanism of injury. Now, please remember that foosh mechanism of injury is also important mechanism of injury in supracondylar fractures in children, in fractures of the shoulder, in fractures around the shoulder joint, that is a clavicular fracture in adults, in Colles fractures in elderly, and also in fractures of the scaphoid in adults. Now, the treatment of the clavicular injuries is usually by figure of 8 bandage or CC sling. CC means cuff and collar sling. Now, the commonest complication in adults in these fractures is stiffness of the shoulders. And the important structures injured in these injuries are the subclavian vessels and the medial cord of brachial plexus. Now, at this point, I would like to ask you a question. Which rib, if fractured, should raise a suspicion of injuries to subclavian vessels? Please think about this and read this through. It's an important topic because one of the ribs, if fractured, should raise high suspicions of injuries to the subclavian vessels as well as the brachial plexus. So, BD 84 में बहुत अच्छा टॉपिक दिया हुआ है फर्स्ट रिब के आसपास के स्ट्रक्चर्स. प्लीज गो एंड सी दैट टुडे. इट इज an important topic from the exam point of view and for your practical point of view also. Now, what are the indications of most of the clavicular fractures? जैसे कि हमने देखा, can be managed conservatively with a CC sling. Now, what are the indications of open reduction and internal fixation in clavicular fractures? So, if there is a non-union of clavicular fracture, that can be managed with an ORIF. If there are neurovascular injuries in the clavicular fractures, that should be managed with an open reduction. Fractures of the lateral end of the clavicle in which the coracoclavicular ligament is torn, that should be managed with open reductions, because in closed procedures, it is hard for us to maintain the reduction if the CCL is torn. We will talk more about CCL in the coming topics. Floating shoulder, that is injuries of the clavicle associated with the fracture below the shoulder joint, should be managed operatively because non-union rates are high in injuries with floating shoulders. Now, if there is tenting of the skin, that is the fracture fragment of the clavicle, since it's a bone which is very subcutaneous, so a clavicular fracture might go up and tent the skin. If there is skin tenting, then that is also an indication for reduction, open reduction. Now, open fractures again is an indication for open reduction and fixation. And if the clavicular fragments, they are overriding by more than 2 centimeters, that is, there is excessive shortening of the clavicle, that is also an indication for open reduction and fixation of the fractures. Coming on to the next topic, which is the dislocation of acromioclavicular joint. Now, in the previous topic, we just talked about how the coracoclavicular ligament may be injured. Now, what is important to see here is that coracoclavicular ligament grows from the coracoid and it attaches onto the clavicle, and that is the most important ligament which is responsible for stabilizing the clavicle in its position antero-posteriorly. Now, coracoclavicular ligament has 2 parts. Again, एक बार anatomy की book please खोल के देख लेना. And if this Coracoclavicular ligament is injured, then what will happen is that there will be subluxation or dislocation of the lateral end of clavicle from the clavicular acromial joint above. So if you can see in these images, what is important to remember is that the first 5 types are the ones which we should be looking for. In type 1, there is only mild subluxation of the AC joint. In type 2, there is some subluxation, but still there is contact between the clavicle and the acromion. In type 3, 4, and 5 injuries, the entire contact is lost and the clavicle is displaced high above the acromion. The commonest mechanism of this injury is direct force to the acromioclavicular joint, and treatment for type 1 and 2 is usually conservative. And if you have heard about Velpau bandage, VELPAU, that is used for acromioclavicular dislocations. This is also a previous year exam question. So Velpau bandage is used for AC joint dislocation. And type 3 to 5 fractures are usually managed surgically by reduction and fixation with various devices, because these injuries are unstable and they are difficult to maintain in any type of bandaging. So this is the important point about AC joint dislocation. Coming on to the next important topic, we have proximal humerus fractures. So proximal humerus fractures, as we all know, there is a very important classification system for it, which is known as the Need's 4-part classification. Now, the 4 parts of this system are divided accordingly as per the anatomy of the proximal humerus. One part is the anatomical neck, the next part is the greater tuberosity, the other part is the lesser tuberosity, and the 4th part is the surgical neck and shaft of humerus. Now, can anybody tell me if there is a very small fragment associated with this injury, when will we classify that fragment as a separate part, and when will we consider it not as a separate part but as a parent bone? So what happens is, if the fracture fragment is less than 1 centimeter in length, and if that fractured fragment is less than 45 degree displaced from the original fragment, then it is considered to be a part of the original fragment and not a separate part. However, if the fracture is more than 1 centimeter in length and more than 45 degree displaced, then it is considered as a separate fragment. So that is important to understand in Need's classification system. Now, what is the implication of why is this Need classification system important? Now, Need classification system is important because it tells us about the prognosis and the management of the fracture. So, what are some salient points about the proximal humerus fractures? The most common complication in these is the shoulder stiffness. Shoulder, remember, is a joint very prone to stiffness, and prolonged immobilization definitely leads to stiffness. So shoulder stiffness is one of the most important complications. The other important ones are avascular necrosis of the humeral head, which is seen in the anatomical neck fractures. Now, again, there is this homework for you to go and read about what is anatomical neck and what is surgical neck, and what is the important structure related to the surgical neck of the humerus. So anatomical neck fractures of the humeral head are associated with high risk of avascular necrosis. Like in the femoral neck, subcapital fractures are associated with high risk of avascular necrosis. Now, surgical neck of humerus fractures may lead to non-unions, while anatomical neck will lead to avascular necrosis. इसके management में in young patients we prefer open reduction and internal fixation. Why? Because we need early mobilization to prevent shoulder stiffness. In old and low demand patients, we can give a simple arm pouch sling or a slab and that will do well. because of the low demand, the patients are not looking for a very active kind of lifestyle. But the treatment should always be decided based on patient profile. 80 साल का इंसान भी active हो सकता है, तो it is important to realize that we should consider the patient's activity levels as well. Now, in a severe combination of needs in an elderly osteoporotic patient, if there is severe combination or there is a 4-part fracture or multiple pieces of the fracture, then the preferred treatment is a hemiarthroplasty, which is replacement of the head of the humerus. So coming on to the next important topic, which is the dislocation of shoulder. Now, this has been asked in your examination time and again, so it's an important topic. The important dislocations of shoulder which we should remember are, number one, the anterior dislocation, which is obviously the most common type of shoulder dislocation. And in anterior dislocation of shoulder, subcoracoid is the most common type. There are other types also, such as preglenoid and infraclavicular, but you should remember that the most common is subcoracoid. Now, there are a few tests which are used to diagnose the anterior dislocation. But first, let's go on to the X-ray and see how should we identify an anterior dislocation on an X-ray. Now, if you can see here, the glenoid cavity, it is empty, and that is one of the most important signs. The next sign is that the humeral head is lying below the coracoid. This is the coracoid. This right here is the coracoid. This is the clavicle. This is the acromion. And the humeral head is lying beneath the coracoid, and the humeral head is overlapping on the scapula. And this is how you can identify an anterior dislocation of shoulder. We will see subsequently how you can differentiate it from posterior also. So some important examinations which are used to see this dislocation is, one is the Hamilton ruler test. Hamilton ruler test mein what we do is we keep a ruler on the acromion, and it should go below, and it should touch the lateral epicondyle of the humerus. But obviously in this case it will not be possible, because in this dislocation what will happen is that the patient will keep his elbow like this. The patient will not be able to adduct his upper limb, and the ruler will obviously not pass through the lateral epicondyle. Now, in the second important test is the Callaway test, and this is increased axillary circumference, which is seen in these dislocations. Dugas test is an important test in which the patient is unable to touch the opposite shoulder from the dislocated side. Bryant's test, the anterior axillary fold is not visible. And the next important sign is the Regiment badge test. Now, Regiment badge test is when there is a patch of anesthesia or hypoesthesia over the lateral aspect of arm. Why? Because there are injuries of the axillary nerve in these dislocations, and axillary nerve, as you can remember, supplies a patch over the lateral aspect of the arm, and this is known as the Regiment bandage test. Now, if you can tell me what associated weakness of the muscle which we will see if there is an injury to the axillary nerve in a shoulder dislocation. So yes, the important muscle which is injured is the deltoid, because axillary nerve also supplies the deltoid, and if there is injury to the axillary nerve, the deltoid weakness will be seen, and the shoulder abduction will be weak even after we relocate the shoulder, and that is an important sign of axillary nerve injury. Now, there are various methods of close reduction for a shoulder dislocation. The Cocker's method was the most commonly used, remember. Hippocrates and Stimson's method are also some methods which are used for relocation of the dislocated shoulder. Now, as we discussed before, injury to the axillary nerve, recurrent dislocations, and brachial plexus injuries are the common complications of shoulder dislocation. And remember that anterior shoulder dislocation recurrence, shoulder is the most important joint known for anterior redislocations. And why, that we will see in the coming slides. Now let us talk something about the posterior dislocation. Now, posterior dislocation of shoulders are usually seen in patients who are prone to seizures or who are undergoing electroconvulsive therapy. In this, what happens is that the shoulder dislocates posteriorly, so the arm will be held in internal rotation and adduction, and there will be difficulty in abduction and external rotation. Now, light bulb sign is seen in these type of dislocations. If you can see here, now this humeral head, which is rotated internally, will look just like a light bulb, and that is why this is known as a light bulb sign. So this is an important sign in posterior dislocation of shoulders. These injuries are hard to diagnose, and again, the treatment of choice is reduction, close reduction. Luxatio erecta is inferior dislocation of shoulder joint below the level of glenoid. अगर यहाँ पर shoulder humeral head पड़ा होगा यहाँ पर, तो that will be known as luxatio erecta. Now, recurrent dislocation of shoulders, as we were talking about, why does the recurrent dislocation happen? So when the shoulder gets dislocated, there are two common lesions which are seen associated with the dislocation. One is known as the Banachard lesion, and one is known as the Hill-Sachs lesion. Now, how to remember this is very confusing. Now, H is Hill-Sachs and H is the humeral head. So remember that the Hill-Sachs is from humeral head. And obviously, Banachard फिर आपको याद आ जाएगा कि glenoid से है, तो remember H for Hill-Sachs and H for humeral head. So Hill-Sachs lesion associated with the humeral head. Now, Hill-Sachs lesion is basically a kind of a bony lesion on the humeral head on the posterior superior part. And likewise, the Banachard lesion, Banachard can be either a bony Banachard lesion or just a labral tear. Now, remember that the shoulder joint is stabilized by the glenoid labrum. This is the glenoid. इसके आगे यहाँ पर एक muscles होती हैं जो कि glenoid का labrum बनाती हैं, जो कि anterior lip kind of होता है glenoid का. And this is important for stability of the shoulder. Now, Banachard lesion can either be a tear in this labrum, which is the commonest type, or it can be a bony Banachard in which there is a fragment of the bone, as you can see in this X-ray, along with the labrum, which has been detached from the original glenoid. Now, remember, Banachard lesion is the lesion of the anterior inferior part of the glenoid labrum. And there is a lot of confusion between whether to mark anterior or anterior inferior in the exam. अगर एग्जाम में anterior दिया हुआ है, तो remember that AIMS के एक एग्जाम में पूछा गया था the same question, and they gave options both as anterior and as anterior inferior, and in that the answer given was anterior. But if that option of anterior is not there, then the best option to mark is the anterior inferior part. Most of the textbooks, remember, mention anterior inferior. So please mark your answer carefully according to what is given in the exam. Now, apprehension test is one of the tests to look for recurrent dislocation. In this, what we do is we stabilize the shoulder of the patient and we abduct and external rotate the shoulder till the patient does not allow you to do the test anymore, because there is this apprehension that the shoulder might pop out of his joint, and this is known as the apprehension test. This is the characteristic test of recurrent dislocation. Now, how do you manage this? That is a complex topic, but if the answer is given as repair of the labral lesion arthroscopic, yes, that is one option. but usually what they ask is the name of the surgical procedure. So Bristow or Lethargic procedure is known to come in your exam, and Bristow and Lethargic surgeries are the most common type used for recurrent dislocation of shoulders. Now, fractures of shaft of humerus. Let's come to the shaft of humerus fractures. Now, if you can tell me what is a Holstein-Lewis lesion without looking at the coming picture, then we can discuss further about this topic. So, fractures of the shaft of humerus. In these fractures, high angular deformities are acceptable. Now, why is that? Because shoulder joint allows for a lot of rotations to happen. And even if there is an angular deformity of the humerus, the shoulder rotation will compensate for it, and hence a high angular deformity is acceptable in these fractures. Now, Holstein-Lewis is a special kind of fracture in the humeral shaft fracture. And if you can see in this picture here, it is the fracture of the distal third of the shaft of humerus. It is a kind of a long spiral fracture. And what happens is that the radial nerve might usually get injured or entrapped in this fracture. And this is commonly known to cause a radial nerve injury. And hence the Holstein-Lewis type of fracture, which is the distal third of the fracture of the humerus shaft, are known for radial nerve injuries. Now, how to manage a fracture of the shaft of humerus? Now, as we can see that the deformities are acceptable in a fracture of the humeral shaft. So fractures without radial nerve injuries can undergo closed reduction and U cast or hanging cast. Again, this has been asked in the exam time and again, which cast is used for a fracture shaft of humerus, and it's the U or a hanging cast which is used. Now, closed reductions जिसमें radial nerve injuries होती हैं, in them what we can do is we can manage with closed reduction and U cast and a cock-up cast. Now remember, a cock-up cast keeps the hand in the position of intrinsic plus. So a cock-up cast is, again, this is another homework for you. आपको जाके पढ़ना है कि एक कॉकअप कास्ट में क्या होता है, इंट्रिंसिक प्लस हैंड क्या होता है, इंट्रिंसिक माइनस हैंड क्या होता है. प्लीज रीड अबाउट इट and do let us know, so we can discuss it in the next class probably. Now, a cock-up cast, so fractures with radial nerve palsy which are closed fractures, we can manage with a cock-up cast and U cast, and these can undergo late exploration if there is no recovery of the radial nerve. Because what happens usually is that the radial nerve injuries in these fractures are kind of neuropraxias. Now, neuropraxias, as you all know, can recover with time. So we can give it some time for recovery. And if there is no recovery, then we should always explore and see why the radial nerve is not recovering. And if the radial nerve palsy occurs while you are reducing the fracture and putting a cast, then there should be immediate exploration, because then what happens is that either the radial nerve had got cut or it has got entrapped in the fracture fragment, and hence you should immediately explore and see why is it so and address the issue along with the fracture. So the next important topic is the supracondylar fracture of the humerus, and supracondylar fracture of the humerus is the commonest fracture in second common fracture in children. It is again one of the foosh injuries or fall on the outstretched hand. Now, the extension type is the most common type. It is seen in about 97% of the children. Now, always remember that the fracture displacement is based upon the distal fragment. So, अगर distal fragment पीछे गया है या आगे गया है या extension में है या flexion में है, that is what determines the type of fracture. So, extension type means that the fracture, we'll discuss it in the coming slide. So, extension type is the most common, and what is important to remember is the 3-point bony relationship is maintained in this fracture. The 3 points being the lateral epicondyle of the humerus, the medial epicondyle, and the tip of the olecranon. Now, the supracondylar fracture will occur somewhere here. So what happens is that the 3-point bone relationship is preserved, and this has been asked in your exam multiple times, which of these fractures bone relationship is maintained. Now, the treatment of choice in these fractures depends upon the type of displacement. There are usually 3 types of fractures, but we are not going to go into that details. In type 1 injuries, the displacement of the fracture fragments is minimal, and they are usually treated by close reduction and casting. In type 2 and 3 injuries, there is large displacement of the fractures, and these are usually treated with close reduction and K-wire fixation. Now, if you can see in this, the distal fragment of the fracture has gone posteriorly, and hence this is one of the extension type of fractures. अगर ये वाला fragment यहाँ पर आया होता और ये वाला fragment यहाँ पर होता, तो distal fragment would have been anteriorly and the fracture would have been called in a flexion. Now, complications of supracondylar fracture is a very important topic, and the most common injury to the nerve is the median nerve. However, this is not the most common overall complication of the fracture. Cubitus varus deformity or gun stock deformity, as they call it, is the commonest complication. This is a result of malunion of the fracture. Remember, supracondylar fractures are not prone to non-unions, they are prone to malunions. So a cubitus varus deformity in a malunion of supracondylar fracture is the most common type. Now, median nerve injury is the most common nerve injury. It is the median nerve. कई किताबों में radial लिखा है, but that is not correct. Median is the most common nerve injury. Radial is the second most common. Now, brachial artery injuries is rare, but an important complication, because if the brachial artery is injured, it is usually by the proximal fragment. Again, this has also been asked in the exam कि कौन से fragment से brachial artery injury होती है. तो anterior part of the proximal fragment can lead to impingement or direct injury to the brachial artery. So brachial artery injury is an important complication, because if this is associated with the fracture, then immediate exploration is needed. Now, myositis ossificans, if there is history of massage around the elbow joint, now you can remember again that myositis ossificans is an important complication in the fractures around the elbow, which have been treated by manipulation or massages by osteopaths. So myositis ossificans में you will find a history of massage by an osteopath or manipulation by an osteopath or by the parents themselves. And the brachialis is the most common muscle in which this myositis starts to happen. Volkmann's ischemia. If you have heard about compartment syndrome, now that is a syndrome in which there is ischemia of the muscles and the nerves. So can anybody tell me at what pressure, at what intra compartmental pressure does compartment syndrome occur? So if the compartment pressure is more than 30 millimeter of mercury, then compartment syndrome will occur. And if the compartment syndrome goes untreated, then what happens is something which is known as the Volkmann's ischemia or Volkmann's ischemic contractures, in which the forearm compartment muscles die and like the hand useless. So Volkmann's ischemic contracture is one of the important complications of supracondylar fractures. And remember that supracondylar fracture in children is one of the most common fractures which is associated with compartment syndrome. So we have to keep a close eye for compartment syndrome in these fractures. Also, if the intracompartmental pressure is more than 30 millimeter of mercury, then that is a diagnostic sign of compartment syndrome. Now, one of the most characteristic signs of compartment syndrome is, what is the most characteristic and important sign for a compartment syndrome? So excessive pain to passive stretching of the muscle group, excessive pain to passive stretching of the muscle group is the most important sign. And in young children or in infants or in very young children who cannot really express pain as an adult can, excessive crying is one of the important signs of compartment syndrome. Now, next, we should come on to the next fracture, which is the lateral condyle humerus fracture. Salter-Harris type 1 or 4 injuries can be seen in these kind of fractures. And if you can see here, this is the lateral condyle. This right here is the lateral condyle. And these fractures are known for non-unions. Unlike supracondylar fractures, which are known for malunions, these fractures are known for non-unions because of pull of the extensor tendons, which are attaching on the lateral condyle of the humerus. Extensor tendons are attaching. So the pull of these extensor tendons will lead to a non-union of this fracture. And hence these are known for non-unions. And it is important. This lateral condyle humerus fracture is one of the fractures of necessity, which means that these fractures must be reduced and fixed because they will otherwise non-unite invariably, or they have a very high chance of non-union. Now, cubitus valgus deformity occurs in these fractures. Why does cubitus valgus deformity occur? Because when there is a fracture of the lateral condyle of the humerus, so what happens is that there is a tendency of this to go, the growth of these lateral part of the humerus starts to get slow while the medial part keeps on growing. And what happens is that progressively the medial part keeps on growing, the lateral part does not grow, so the elbow goes outwards, and that is known as a cubitus valgus deformity. Now, these are known for tardy ulnar nerve palsies. Tardy means slow onset, and these ulnar nerve palsies can be seen as late as 20 years from the date of injury. So, cubitus valgus deformities due to lateral condyle humerus fractures are known for tardy ulnar nerve palsy. Remember. The next important topic of discussion is the dislocation of the elbow joint. Now, dislocation of the elbow is common between 10 to 20 years of age. And the most common type is the posterior dislocation. It may be posterior medial or posterior lateral, but posterior is the overall most common type. Now, median nerve is the most commonly nerve injured in these type of injuries. A step sign is present in dislocation of the elbow, which differentiate it from a supracondylar fracture, because low supracondylars can mimic a posterior dislocation of elbow. Now, what is important in these injuries is that the 3-point relationship between the lateral epicondyle, the medial epicondyle, and the olecranon process, it is reversed because the dislocated elbow will be high or upriding, and hence this relationship is reversed, and this is one of the characteristics of dislocation of the elbow. Now, myositis ossificans, again, as we know that injuries around the elbow can lead to myositis. So myositis ossificans is an important complication. Now, remember, myositis ossificans, if we are talking about it, so there are myositis ossificans traumatica and myositis ossificans progressiva. Now, myositis ossificans traumatica usually develops after traumatic injuries, but myositis ossificans progressiva is a disease of genetic disorder, and in that trauma is not needed, but it will anyways lead to myositis. So always read important. It's very important to read in your MCQ whether myositis ossificans progressiva is given as an option, because if they are talking about trauma and then myositis progressiva is in the option, then that might well be the answer to that question. Now, pulled elbow or nursemaid's elbow, what I want to ask you is, what would you find in that X-ray of a pulled elbow? So the X-ray of the pulled elbow is essentially normal. There is no finding in the X-ray of the pulled elbow. These are also known as nursemaids or temper tantrum elbow. So what happens is when the child is held by his or her hands and they are pulled, that is when these injuries occur. They are usually in seen in children less than 5 years of age, particularly when the child is lifted by forearm or wrist. Now the head of the radius is pulled out of the annular ligament and the child keeps the forearm pronated. This is an important hint in your exam question, that the forearm is usually pronated and the x-ray does not reveal anything. So the simple treatment for these injuries is supination and direct pressure, which will pop the radial head back into the annular ligament, and the child will be happy again and he will be moving his arm. So remember, pulled elbow, no x-ray signs, and simple treatment by supination. So side swipe injury is the injury which is also known as a baby car fracture or a traffic elbow. In this, what happens is that when some passenger is putting his hand outside the window and some other vehicle which is passing by just hits the elbow, that is when this happens. इसीलिए हमें बचपन से बोला जाता है कि बेटा अपना हाथ कार से बाहर मत निकालो. So the next important topic is the radial head and neck fractures. Now, radial head fractures is common in adults while neck fractures are common in children. The most common nerve injury associated with this kind of fracture is the posterior interosseous nerve because it is closely related to the radial head and neck. If you can remember that the radial nerve divides into posterior interosseous nerve and passes behind the radial head. So an injury to the head and neck can cause injuries to the posterior interosseous nerve. This is associated with something which is known as the terrible triad of the elbow. And in the terrible triad, what you will see is that there will be a fracture of the radial head, there will be posterior dislocation of the elbow, and there will be a fracture of the coronoid process of the olecranon. So remember, terrible triad of the elbow again has been asked as a question. Now, coming on to the next topic, which is the Montejus fracture. This is a hyperpronation injury. Hyperpronation means that the patient falls on an outstretched hand with the arm held in pronation, and that is when this injury occurs. This is a hyperpronation injury. The most common type of Montejus is anterior, in which the dislocation of the humeral head is also anterior, and the fracture of the ulna is also anteriorly angulated. So anterior is the most common type. Remember, this is a fracture of the proximal third of the ulna with dislocation of the proximal radio-ulnar joint. So fracture of the proximal third ulna with proximal radio-ulnar joint dislocation is the Montejus fracture. Hume's fracture is a fracture of the olecranon itself. This is the olecranon. So the fracture of the olecranon along with this similar type of injury in children is known as a Hume's fracture. Now in children, this can be managed conservatively with a close reduction, but in adults, this should always be reduced and fixed. The ulna is reduced and fixed with a plate, and the radial head usually falls into place. If it does not, then what we do is we put a wire so that the radial head stays where it should. Now, where should the radial head stay? That is the next question. So the radial head in all x-rays should correspond to the capitulum. So a straight line drawn through the axis of the radial head should pass through the capitulum. This is the thumb rule when looking for a radial dislocation. In this, the head is lying way above the capitulum here. Capitulum, this is the capitulum. So the radial head is lying way above here. So when in the right position, this line should be passing through the capitulum, and this is the rule of thumb for a radial dislocation. Now, Galeazzi's fracture is the fracture of the distal third of the radius and subluxation or dislocation of the distal radio-ulnar joint. This is the Galeazzi's fracture, and the treatment of choice in this type of fracture is ORIF or open reduction and internal fixation. Now, this has also been asked in your exam multiple times, that in which position should a fracture be splinted for the best results. Now, if it is a fracture of the both bone forearm, which is of the proximal third. Now, in the proximal third, if you remember, the muscle which attached to the radius are the biceps and supinator. So the proximal third fracture should be held in supination for best reduction. The middle third fractures, the pronator teres attaches onto the radius and it has a tendency to pronate, and these are best held in a mid-prone position. And the distal third fractures, the muscle attaching onto the radius is the pronator quadratus, and these are best reduced in a prone position. Coming on to the next very important topic, which is the Colles fracture. Now, Colles fracture is usually a fracture of the elderly females in which there is osteoporosis. So when they fall on an outstretched hand, again a push injury, and they try to break their fall by keeping their hand out. So what happens is the fracture happens here or at the corticocancellous junction of the bone, and this is known as the Colles fracture. Usually it happens around 2.5 centimeter above the wrist joint, and it is characterized by this dinner fork deformity. Dinner fork deformity occurs in a Colles fracture. Now, what is the most important thing about Colles fracture? They can either be managed conservatively or operatively. Conservative management we can close reduce them and cast them, and then get x-rays done to see if the reduction is appropriate, or we can open reduce them and fix them with plates or wires. The most important thing in Colles are the complications associated with it. So the most important complication or the most common complication of a Colles fracture is the stiffness. Because of prolonged casting, there is stiffness of the wrist or the fingers and even elbows. If the patient does not move his or her elbows, so there can be stiffness of the elbow. So stiffness is the most common complication of the Colles, finger stiffness being the most common. Now, Colles fractures, if left untreated or improperly treated, are prone to go into malunions. They usually do not go into non-unions because it's a cancellous bone, so they are prone to go into malunions. So that is another complication of Colles. Carpal tunnel syndrome can occur because when this fracture happens, because of the deformity, the median nerve might get compressed here, and that can lead to a carpal tunnel syndrome. Now, Sudex osteodystrophy, which we nowadays call as complex regional pain syndrome, is basically a complication of Colles fracture in which there is redness, tenderness of the overlying fingers even after the fracture has united, and even months after the fracture has united, there might be redness and swelling of around the fracture or around the distal part or the fingers. There will be stiffness of the fingers. There will be hyperalgesia, which means that there will be excessive pain on touching. And Sudex osteodystrophy is usually managed by drugs such as SSRIs. So SSRIs or antidepressants are usually given in this complication to manage it, other than physiotherapy and exercises, of course, which is the most important part. Now, extensor pollicis tendon rupture. If you can remember that the extensor pollicis tendon goes from here, loops around the radius, around the tubercle, and goes on and attaches into the base of the thumb. So the extensor pollicis tendon can rupture because of malunion of the fracture, and that is one important complication. Hand shoulder syndrome. Now, if there is a fracture in the hand, there can be stiffness and pain in the shoulder region also, and that is something which is known as the hand shoulder syndrome. So hand shoulder syndrome is another important complication of the Colles fracture. In Colles fracture, one more thing which we should remember is the types of deformities which are associated with it, which is impaction, supination, lateral rotation. Now, that is one homework for you to go and read what are all the deformities associated with the Colles fracture. I'll tell you three: supination, impaction, and lateral tilt. So next we have something which is known as the scaphoid fracture. Now, scaphoid fracture is another type of push injury which happens because of fall on outstretched hand in adults. Now, the most common carpal bone to fracture is the scaphoid bone, and the oblique view is the best to see this kind of fracture. The most common site of this fracture is the waist of the scaphoid, and there is tenderness in the anatomical snuff box. Now, if the waist of the scaphoid is fractured, what is important is that there can be avascular necrosis of the proximal part because of the blood supply of the proximal part, which is precarious and comes from the distal part. So if the waist is fractured, the blood supply might be hampered, and this might lead to an avascular necrosis of the scaphoid. The scaphoids are best casted in a glass holding position. Okay, before we go on to the questions, again, I would request you to go and subscribe for our Nextillo's helping hand package. We are giving great discounts at very minimal prices, and it will go a long way in helping you to clear your concepts and clearing your exams. So coming on to the questions. Now, who can answer this for me? Avascular necrosis of the scaphoid is also known as, which of the following is correct, do you think? So the answer here is A, or Pricer's disease. Pricer's disease is the what is known as avascular necrosis of the scaphoid. Now, Kienbock's disease. Who can tell me what is Kienbock's disease? It is also another one of the scaphoid के आसपास की bone होती है जिसमें problem होती है. Kienbock's disease. So Kienbock's disease is basically an avascular necrosis of the lunate. Now, the commonest fracture of upper limb in children is, so the most common fracture in children in the upper limb is the clavicular fracture. So clavicular fracture is the most common fractures in the upper limb, closely followed by supracondylars, and then next we have the both bone forearm. So garden spade deformity is seen in. So we have talked about dinner fork deformity. Dinner fork deformity we have already talked about, which is seen in the Colles fracture. So garden spade deformity is basically the reverse of the Colles fracture deformity. In the dinner fork deformity, what we see is something like this going on, while in the garden spade deformity, what we see is something opposite of it going on, something like this. So garden spade deformity is usually seen in the opposite fracture of the Colles. In Colles, there is dorsal tilt and dorsal displacement of the fracture fragments. In Smith's fracture, there is a volar tilt and volar displacement of the fracture fragments, and hence garden spade deformity is seen in a Smith's fracture. Treatment of choice in an impacted knee type 2 fracture in elderly is. Now, as we have discussed earlier, that in elderlies, we should always consider how much is the functionality. Now, in this question, the examiner has given you two hints. He has said impacted and he has said knee type 2, which means that it's a two-part simple fracture. And it is an impacted fracture, which means that the two fracture fragments are impacted into each other. Now, when these are impacted, there is a high chance of union of these fragments. And hence, an impacted knee type 2 fracture in elderly might simply be treated by a CC sling, because these will usually unite and the functional result will be as good as any other treatment method. Most common nerve injury in supracondylar fracture in children is. So what do you think the answer should be? So as we have discussed before, the most common nerve injury in supracondylar fracture in children is the median nerve, right? The median nerve is the most common injury in a supracondylar fracture in children. which is the extension type. Now, if the question does not mention anything about the extension or the flexion type, you have to assume that it is the extension type, because the extension type is the most common. However, if the question mentions that in the flexion type of fracture, then the answer changes. And I would like you to read about this. What is the most common injury in a patient of supracondylar fracture in a flexion type of injury? Okay, so this is another interesting question. Identify the nerve injury commonly seen in this fracture. So this question has basically two parts. And as I elaborate upon this, you can very well go and answer this question. This is the question of the day, the last question of the day. And if you can see here, what you see is a fracture of the distal third of the radius and dislocation of the distal radioulnar joint. So this is a Galeazzi's fracture. Now, the next part of the question says, identify the nerve injury commonly seen. Now, this question basically tests your applied anatomy, because the nerve injury commonly seen will depend upon whether you know which nerve is going to pass near this fracture fragment. So what do you think the answer should be? So I'll give you another half a minute to find out the answer to this question and see what you come up with. All right, so what usually happens is this fracture is that the median nerve passes close to the radius at this point, not the median, but the anterior interosseous nerve to be precise. So if the answer to this question in this option was an anterior interosseous nerve, then that should be the best answer. But in this case, since that is not in the option, so the median nerve is the best answer. The median nerve injury is commonly associated with this fracture. It was a hard one, but I hope you guessed it. Anyways, this is all for today. I hope you liked and this lecture. So let's hope you like and subscribe our Nextillo app, and hope to see you again very soon. Goodbye and good night. And of course, a very happy Holi to all of you.